I think
We
so.
engage
Yeah, sorry,
collaterals. Yeah, there is a stenosis distal
Thank
there,
you.
but the guidewire is good. Yeah, it passed. Perfect. Yeah,
So
let's
thank
fix
you very much for the
with
invitation.
the
I'm Zoltan
2.5, the
Ruzsa
distal
from
AT.
Hungary. I'm interventional
We will use the
cardiologist,
Oscar balloon
angiologist,
to
doing
pre-dilate
a lot of interventions, more or less CTOs
the
and
pop,
complex
and
procedures.
finally we will
My
see
talk is
if we
about
need a
now
stent and which
the
stent.
physiological investigations during lower limb intervention.
Yeah, one
So
of
if you have
my
a
suggestions
CLI,
for the
the
Oscar
distal pressure
was to put a
decreases,
distal
we have
marker on the
infection,
balloon, because we
inflammation,
are now
but always the pathophysiology is a decrease in the pressure. How can we assess the result after the PTA or before the intervention? We can do angio, we can do digital angio, pressure measurements, we can measure the gradient, and also we can measure the flow. But otherwise, this is not satisfactory in many diseases, pathomechanisms, because in short borderline lesion, we don't know. In long lesion, haziness, long multiple lesions, like before, it was a long anterior tibial and popliteal intervention. So do we have a good result? We don't know after the intervention. We just measure the flow and we just do the angio, but it's not enough. In this lesion, it's very easy, it's short. We put a stent, drug-eluting stent is nice result. But in these lesions, in the long lesions, is this final result nice? We don't know with dissection here, it's okay here, another dissection, so we cannot tell the truth. Another case is like the other case, we have popliteal anterior occlusion. Okay, we do with one stent and drug-coating balloon, but is this result good? We don't know on a long term, just in the acute setting. We can measure the flow, or we can, of course, we can measure the blush in the wound, but after intervention, we don't know whether this patient will heal and the wound will heal also. So fractional flow reserve was introduced to measure lower limb pressures also. It's not just, it's done with a pressure wire. We go distally and then we measure the resting gradient, and then we give papaverine and we introduce ischemia. The stuck of the slides. Yeah, cannot go forward. Maybe there is some problem with the presentation because this was not that slide which was coming. So FFR is a very good method because we can go directly with the guide wire through the lesion, and we can measure directly the pressure. First was correlated with the ABI in iliacs, so we can is very good correlation with the FFR. It's not going. Sorry, but. So this is one case of mine. It's an LAD lesion with the right. I measured, of course, the LAD, the diagonal, and the right, and no one was treated because there was no significant difference. And the patient has also claudication. So this was the lesion in the right iliac, which was. Can you push this? It's not working. So this was a borderline lesion, and I measured the FFR. Which was 74, and the gradient, systolic gradient was 25, so it was significant by pressure wire. So we could put the stent, and then finally we could achieve a good angiographic and FFR result. In the femoral also we can measure the FFR. FFR measurements can be introduced by papaverine or adenosine. It correlates very nicely with the ultrasound measurements, and after the intervention, it correlates also with the restenosis at 1 year. Also, if we measure for stenting, so if you put a stent and then we measure the pressures, also it's a very nice correlation of the restenosis in the SFA. So it's very good not just for intervention but also for assessing the final result. Another publication, it was found that 0.74 cutoff, such in coronaries, is very nicely associated with the stenosis severity by ultrasound also. So this study we started now, the probe trial. We randomize the patient in FFR-guided strategy and normal angio-guided strategy. And if the FFR is high, we don't treat the patient, we just do medical treatment. If the FFR is low, then we treat the patient and we check the 1 year results of this patient. So angio group, FFR group, and FFR, we have two groups, treat or defer. This is a case from the study. We see that there were calcified nodules in the SFA1 nodule, another one, and here was the third one. This is the FFR, is 0.71. We see the flow is not perfect also, so I dilated with the balloon. This is under balloon dilatation. It also shows the distal pressure. So this is the pressure what gives the profunda. So sometimes we can check also not just the stenosis severity, but the collaterals also. And then after the intervention, so this is the result. We have some B-type dissections, but not severe. I dilated the DCB. This is the result, and we have a nice pressure. The patient is now asymptomatic, and we will see, of course, at 1 year. For the below the interventions, we conducted a study 10 years ago. So we started to do, this was one case with the old pressure where it was a long anterior tibial artery CTO. After the intervention, we see that the pressure has been normalized and FFR is nice also. The patient had been recovered, also the wound has been healed. The pressures has been improved after the intervention, also the FFR in this study group, and there was a nice correlation with the area stenosis before, after the intervention. Also, we correlated with the laser Doppler, so it was a nice correlation between the pressures and the laser Doppler parameters during the intervention. And these are the wedge pressures. It's very interesting to see the physiology behind the disease. If we have one CTO, 2 or 3 CTOs, if we have 2 CTOs, the pressure is very low and we don't have so many collaterals. This is a case from a study, anterior tibial artery occlusion, and then we have done the intervention. We see that the FFR before was 0.66, after the intervention 0.83, and these are the laser Doppler parameters increasing the change in the DPU and transcutaneous oxygen, and these are the FFR results. If you check the 10-year mortality after this small study, these are the before-after pressures. Also, we see the FFR and the 2 pressures. There's a good correlation. And what is important, after 10 years, we see that if the FFR was low or normal after the intervention, or higher than 0.8, we had a nice male event. So it's good prognosis for 10 years, not just in acute setting. So if the FFR is good, we will have a good result on the long term also. This is a case I've done recently. It's an anterior tibial artery stenosis here in the ostium. Distally, there was a diffuse disease also. So this was the FFR 0.72. This is the RFR pullback. If you pull back the catheter, you can measure, you can locate the stenosis. So these 2 stenosis were responsible for the ischemia, and this is the distal perfusion. We just ballooned it, of course, with one DCB. We see that we normalize the pullback also, and the FFR is 0.87 also. And here we see the distal perfusion, how nice it is, and also the patient recovered. Can we go forward? Stuck? Excuse me? Yeah, it's not working. Can you go forward? Pedal pressure is another, because we treat a lot of patients from pedal pressures. By pedal pressures, before and after intervention, we can check also the pressures. First, it was with American colleagues, we correlated the pedal pressures and the ABI, and it was a nice correlation. So you can check immediately the pressure, and here is how the pedal pressure improves. And also the quality of life improves. So if the patient pedal pressure improves after the intervention, their quality of life and walking distance improves. So it's very important message that if we do a good intervention from transpedal and the pressure is good, then we have a good result. This is a patient with SFA disease from pedal, and we see the pressure is 81. We dilated, it was 82, but you see some dissections after POBA. Somebody would leave it, somebody would stent it. Due to the pressure, I decided to put a short 4 French compatible stent from transpedal, and the pressure is 140 after the intervention. So we could improve immediately significantly the pressure. Stuck again? Excuse me? I don't know what is. Yeah. We measured also the distal pressures in a BTK intervention. Can we go forward? Something is not okay. Now it's okay. So during the BTK interventions, if we treat this patient from transpedal way, we see that the pressures are improving, and we see the baseline pressure in Rutherford 4, 5, 6. We see that in patients with gangrene, we have low pressures. In patients with Rutherford 4, 5, the pressures are not so bad. So we see that it's a fully different mechanism. We have not so many complications, and these are the outcomes. In the patients with amputation and no amputation, in patients with amputation, the final pedal pressure is lower, and the cutoff of the 3 months bad results are if the index 0.58, and if the pedal pressure was up to 108, then we have a good outcome. This is a patient with a CLI, anterior tibial stenosis. We have done with just a free French Cook sheet, ballooning, and after the intervention we had 160 mercury. So we could improve the pressure, and the patient healed, had a good healing, and this is the laser Doppler after the intervention. Another complex case, anterior tibial artery stenosis, popliteal occlusion, and this is the laser Doppler. We see there's no perfusion distally. So this is the pressure down. You see is almost 43. So we went up. Okay, we opened this popliteal, and then there was another stenosis. We dilated, and you see after the intervention we have a good pressure, and also the distal pressure is 184. So we could improve with 100 mercury the distal pressure during the intervention. So we can say that lower limb intervention can be optimized by pressure wire or transpedal pressure measurements, depends from where you are working, from antegrade or from retrograde. Femoral stenosis FFR volume correlates the best with the Doppler ultrasound. BTK stenosis FFR 0.8 volume correlates with laser Doppler. And CLI patients has worse outcomes if the FFR is less than 0.8. CLI patients has worse outcomes if the final pedal pressure is less than 180, or the index, the PAPI index is less than 0.48. So we have a good improvement like this. Thank you very much for your attention.
Thank you very much, Zoltan. Questions? Okay. If I can. Thank you very much. Excellent presentation. I totally agree that we need something more than angiographic control and angiographic indications for treatment of the lesions of the lower limbs. And this is something very, very positive because it's functional, and we really can imagine what happens, especially if there are lesions we are not sure should be treated more, and so on. So, very good. Thank you. The next presentation, endovascular treatment of post-thrombotic syndrome.
Hello, my name is Dr. Peter Georgiev. I will tell you about our venous cases in the Sofia Med Hospital. So endovenous stenting is increasingly performed for iliac and inferior vena cava occlusive disease. Iliocaval occlusions can be asymptomatic or can cause severe chronic venous disease. IVC involvement results in more complex endovascular procedures. Who, when, and how should be treated? So that is our first case, 70 years old female, 2012, left iliofemoral DVT with PE. The PE recidives in 2013, 2015, while on adenochromatoma. Is C-up4 and 300 meters on venous coagulation. The duplex ultrasound showed us patent left popliteal, and common femoral vein with occluded iliac and suprapubic and pelvic collaterals. Femoral and popliteal veins was with reflux, patent right leg veins. On the CT phlebography, we saw post-thrombotic, small size, totally occluded common iliac vein. This is the initial phlebography. You can see the big collaterals going to the other side. So we performed a recanalization. After we are sure that we are on the IVC, we did a NIVUS, which showed that the whole segment was diseased below the ligament. So we did angioplasty with smaller balloon, then with a bigger balloon, and then we put a wall stent across the ligament. Firstly, because the wall stent, it has really nice radial force at the middle, so it should be placed carefully. After that, we continued with Venovo stent from the IVC without touching the contralateral wall of the vena cava. So this is the result. No more collaterals and good flow. So post-operative therapy was low molecular weight heparin for 14 days, followed by rivaroxaban, clopidogrel for 30 days, and second-class compression stockings. We put it on the table right after the... we did a duplex ultrasound on second week, third month, and sixth month. We saw patent iliofemoral stents, minimal deep vein reflux, and clinically asymptomatic. The second case is 34-year-old male with edema on both legs, 200-meter coagulations. The ankle brachial index is above 1, so there is no arterial disease. Bilateral leg ulcers for 5 years with multiple recidives despite the compression therapy. It has a large history, 2004, iliofemoral thrombosis, treated 20 days with heparin, and followed by adenochromatoma and compression stockings, 2005, on the phlebography, minimal recanalization of the femoral veins, total occlusion of the iliacs and the IVC. 2010, the venous ulcer formation started. 2013, he got tested and got factor V Leiden and prothrombin mutation, so which means lifelong anticoagulation. The duplex ultrasound showed post-thrombotic popliteal, femoral, and iliac veins with reflux. No IVC can be detected, really big collaterals in the abdomen. The CT phlebography showed us post-thrombotic iliofemoral veins with good recanalization, big diameters with minimal intraluminal defects, small hypoplastic IVC, normal diameter only at the most proximal part. This is 3D reconstruction of the CT phlebography. You can see how much collaterals it's got. And this is the vena cava, which is either post-thrombotic or hypoplastic. And you can see the vena azygos, which is really big. So this is the initial phlebography. We started recanalization looking for the IVC at the most proximal segment. After we are sure we are there, we started with ballooning and preparing for stenting. We put 3 wall stents, as you see, 16 and 14 by 90. On the final phlebography, we can see direct brisk flow on the right iliac vein, and also equal filling on the IVC and collaterals on the left one, so no need to put stents on the left vein. Post-operative therapy, full heparinization and clopidogrel, verticalization with elastic stockings, and again, anticoagulant and clopidogrel for discharging. The result, reduced pain and increased distance with walking, ulcer epithelialization achieved for 2 months and no recidue for 10 years. Follow-up 10 years, again, first, third, and sixth, 12 months, yearly. Patent IVC, no change in the deep vein reflux, and increased variability of femoral vein while breathing. This is the first year 3D reconstruction of the phlebography. You can see a nice stent with each patient. The left iliac is also good. The third case is a 37-year-old female, 2010, iliofemoral-popliteal DVT, and 24-year stenting of the right iliac vein for post-thrombotic changes. The duplex ultrasound showed patent right popliteal and femoral and occluded iliac vein stents at the distal part. Femoral, the VFK, the femoral vein was with really big post-thrombotic changes. Patent left leg, from the CT phlebography, we saw occluded stents in the iliac vein, post-thrombotic changes in common femoral vein. So this is the initial phlebography, occluded stents at the proximal part. We did a thrombectomy, open one, with an open access. Then we did endophlebectomy because this was in the vein, so we couldn't stent it until there. After that, we did a xenograft patchplasty, and that was the final result. On the profunda, there is a vessel whoop, it's not stenosis. So the second, the second day, we had thrombosis of the whole thing. We open again, and this was, this is the part between the last stent and the patchplasty. So there were a segment which thrombosed the first day, and then we put one more stent that proves that when you stent veins, it should be from nice vein to nice vein. We gave her low mercury heparin for 14 days, followed by rivaroxaban, clopidogrel for 30 days, and second-class compression stockings. We saw her this week, and everything is good now. So what can cause ileocava obstructive lesions, post-thrombotic thrombophilia, cava filters, compression, tumors, or May-Turner syndrome, and agenesia. Treatment can be surgical, not perfect results, endovascular with good results, and hybrid. This is Gelari classification. So the first three types, especially type 1 and type 2, show really good result after stenting. Type 5 has a really high rethrombosis risk. Diagnostic workup, ultrasound, CT or MRV. Venography is not too sensitive because it's two-dimensional and we cannot see intraluminal fibrosis, webs or membranes. So IVUS is the golden standard. Stenting of the iliocaval segment, it has extremely low morbidity and the effectiveness is almost 100%, and 89% for post-thrombotic to 3 to 5 years. So chronic total occlusions of the IVC, 85% technical success, up to 93% for primary assisted and secondary patency rates at 16 months, significant improvement of pain and swelling, healing ulcer completely without recurrence in 78% after recanalization. This is the technical aspects. We have femoral popliteal and jugular access. We should use big balloons. This is the sizes of the different veins, and that's the minimal. The perfect way is to measure it by IVUS. Different configurations are possible to reconstruct the IVC in bifurcation. In a lot of cases, it can be stented only one side and to be acceptable. If you stent across the renal veins, you can check if there are good collaterals to azygos vein. So if you have it, there's no problem to stent the whole vena cava. So treating the combined occlusion, reflux, iliac venous standing alone sufficient to control the symptoms in the majority of the patients with combined outflow obstruction and deep reflux. So conclusion, obstruction is at least important as reflux in post-thrombotic disease. In case of poor conservative treatment, results workup for outflow obstruction should be performed and standing discussed. Even in challenging long segment iliocaval total occlusions, technical success, mid-term results are encouraging. Big stents and use of IVOs and IVOs is essential. Sorry for the time.
Any questions from the audience? And
so in case when you don't have any inflow,
Siga?
what do you do to remain your reconstruction patent?
So there are cases with endophlebiectomy. If you can do profunda, it will be so okay. But you can go from tibial vessels and do some, if there's acute phase, you can do fibrinolysis and try to open the popliteal femoral vein. And that's the things.
Къде е Пете? Да пускаме.
Just one question to you, just for sport. No, it's a very interesting lecture, and congratulations, you started more than 10 years ago. So, do you use, 10 years ago you have done with the wall stent?
Now go.
What have been changed with the wall stent, with the old wall? But now is 2026, which stents do you use for iliacs and which stents do you use for vena cava?
Yeah, okay, Venovo stents are nice. My boss will tell you more about the choosing of the stents because it's his presentation actually. So.
Well, nowadays it's a question of money. We still have only a wall stent reimbursed in our country, and all the other stents are too expensive. So some patients can afford these expensive stents, and in any case we can use Venovo or Abre. It's better, of course. In some case, I haven't used Zilver.
Let's wait.
Also some Optimed stents.
I will repeat up.
Yeah.
Yeah. Optimed is very good for radial force.
Also,
Yeah, I think so.
but it's a question of money.
Yeah.
what do you think about the venous stent graft
Чуваме ли се?
in a cavo and iliac segment?
The problem with these lesions that the occlusion rate is very high, especially if you protrude in the vena cava and if you protrude to the common femoral vein. So I would put the stent graft in the vena cava, but down not. But I fully agree with using